want to welcome all of you here, and I see the administrator of SAMHSA here, Pam Hyde, and lots of others of you that I've known over the years, and welcome. Our format today will be that I'm going to ask Arthur Evans to speak for about 10 to 12 minutes to kind of start it up here, and then we will hear from Bill and Brandon, and I'll introduce them as we go. What I thought we might want to do is start, since this is Boston, and it's the home of John F. Kennedy, and as Bill said, I've been around in this business probably close to 50 years. I remember the president, and actually when I was in college, worked for him to get the presidency of the United States. And I just want to take for 1 minute to read you something that was his words. John F. Kennedy was, I think, something of a role model to those of us that started out in the 60s. The Community Mental Health Center Act really determined my career. And one thing that unites us all is mission. And I just want to read to you something that John F. Kennedy came before the House of Representatives, or our Beacon Hill, to our Senate and House, and talked to them before he left to become president. And this is what he said. When at some future date, the High Court of History sits in judgment on each one of us, recording whether in our brief span of service we fulfilled our responsibilities to the state, our success or failure in whatever office we may hold will be measured by the answers to 4 questions. First, were we truly men and women of courage, with the courage to stand up to one's enemy and the courage to stand up when necessary to one's own associates? Secondly, were we truly men and women of judgment of the future as well as the past, of our own mistakes as well as the mistakes of others, with enough wisdom to know when we did not know and enough candor to admit it? Third, were we truly men and women of integrity, men and women who never ran out on either the principles in which they believed or the people who believed in them? And finally, were we truly men and women of dedication, devoted solely to servicing the public good? Courage, judgment, integrity, dedication. These are the qualities of us that work in this field. I obviously changed a few words, but I think for those of us that are public servants or have been public servants, this has been an important part of, I think, of our lives, that we stay true to our mission and to the values that we all cherish. So without further ado, I will introduce Arthur Evans, Dr. Evans is the Commissioner of Mental Health and Intellectual Disabilities for the city of Philadelphia, and he's going to give us some opening remarks.
Sure.
Thank you.
Good. Well, thank you, Mary Jane. Just want to say great thanks to Patrick Kennedy for inviting me to be here, and Bill Emmett. So I guess I'm supposed to try to do a little bit of framing around this issue. So just a little bit about myself to let you know what my perspective is. I am currently the Commissioner of the Philadelphia Department of Behavioral Health and Intellectual Disability Services. Been in the position for about 9 years, and prior to that I was the Deputy Commissioner for the Connecticut Department of Mental Health and Addiction Services. So for about the last 15 years I've worked at the policy and systems administrator level, and that's a perspective that I want to bring to the discussion today. We heard a really great synopsis of what's happened as a result of the Community Mental Health Act that President Kennedy signed. I would just say, and I won't go over that, but I think out of that, that has brought us to the point where we are today, where we are really embracing the idea that people with even the most severe forms of mental illness can recover. And in fact, the research shows that 2/3 of the people who have even the most serious forms of mental illness can recover. And frankly, that's not the way most of us who are in the field were trained. We certainly aren't trained that way. Our systems aren't designed with recovery as the outcome. And it's really the reason why mental health systems, behavioral health systems around the country are reorienting around the idea of recovery. And we certainly did that in Connecticut. I'm doing it in my work in Philadelphia. So I want to say that this idea of prevention, early intervention, in my view, comes and builds off of this work over the last 50 years. And what I want to talk about is what does the next 50 years look like? I think that if you look at what happened as a result of President Kennedy's bold vision about mental illness, it not only led to deinstitutionalization. So we had over 500,000 people in institutions at the time that he signed that act. We have probably somewhere around 50,000 today in institutions. But I think more importantly, it signaled a paradigm shift. And so what I want to argue is that as we think about the next 50 years, what's the paradigm shift that we want to make? And I want to argue that now is a really critical time for us to look at that as a field. And I think the idea of prevention, early intervention is what that vision ought to look like. And I'm going to talk about that in a moment. What I would say is this, that as a field, even though we've made a tremendous amount of progress, we have some very significant challenges. And I want to describe one that kind of comes out of recent headlines where you've had people who've been involved in some pretty tragic events who have had mental illness. For those of us who manage systems, there are sort of two groups of people that we have to deal with, or that we are often working with. People who have a mental illness, who recognize it and voluntarily come into treatment. You also have a group of people who are a danger to themselves or others, and don't have insight into their illness and have to be involuntarily committed. For those of us who administrate programs, there is this gray area. I've written an op-ed piece on this, where you have people who are in a prodromal state, they're at high clinical risk, they don't have insight, but they're not in a position that where they need help, but they're not in a position where they can be involuntarily committed. Those are the folks that keep people like myself up at night, because they have needs, they don't necessarily have insights. And the way we financed our system, most of our resources are in the treatment world. So I have a budget of over $1 billion. Less than 2% of that is spent on anything outside of treatment. So for prevention, early intervention, those kinds of things, we have very little resources. It is a huge problem for us, and until we can shift our thinking and our resources to accommodate and deal with people who are in a preclinical point in their condition, we are not going to be able to reach people who really need our help. So I think that what we have to do as a field is really move to a public health way of thinking about our work. One of the things that's really exciting about the period we're in right now is that we have, and we heard earlier today, this idea of parity. I would suggest that, number one, I think that's a great thing that we have parity. But I would suggest that we thought about parity within the confines of treatment. So if we have equal access for behavioral health conditions as physical health conditions into treatment services, that we have parity. And I think, again, that's great. But I would suggest that parity also means that we think about behavioral health conditions in the same way that we think about physical health care conditions. So, and I'll give you a quick example. If the behavioral health world was in charge of the latest flu epidemic, our approach to solving that would have been to build more hospitals. If you think about it, because that's where we put all of our emphasis. Whenever there's an issue around mental illness, addiction, the answer is always we need more treatment. I'm not arguing against that. But we also need more flexibility in our resources so that we can use other strategies. So when the flu outbreak happened, we taught people how to wash their hands and all kinds of other ways to prevent, to prevent people from actually developing the flu. So the issue for us, I think, is what are those kinds of strategies that we can use that will prevent, that will ameliorate, where we can intervene early so that people don't need treatment or don't develop very significant illnesses. So I want to use 5 points that I think illustrate this point, this idea of moving from our current emphasis on treatment to really thinking broader and using a public health approach. So one notion is this, that in physical health, we think about population health. There are lots of examples of where, for physical health, we think more in terms of population and interventions at the population level. In the behavioral health world, we think almost exclusively at the individual level, perhaps somewhat at the family level, but we don't think about population interventions. I want to talk about that. Secondly, obviously moving further upstream and having more interventions that are designed to intervene early and to prevent mental illness, to prevent addiction. Again, we have very few resources that are dedicated to upstream, and furthermore, we don't have a workforce, even if we had the resources, to actually address more upstream strategies. And there's some things that we've been doing in Philadelphia that hopefully we can talk about where we're trying to do that. Thirdly, from a public health standpoint, we need a broader range of interventions. Currently, we use primarily, to deal with any behavioral health issues, psychotherapy, medications, and perhaps case management or other kinds of supports. You think about physical health, we have a whole range where there are policies, strategies, we put fluoride in water, there are all kinds of strategies that we use. And I think the question for us, are there analogs that we can use from a behavioral health standpoint? So for example, in Philadelphia, one of the things that myself and the health commissioner are looking at is a concentration of alcohol programs or alcohol stores within communities, because we know that when that happens, you have a whole host of issues, behavioral health, but a lot of other really negative things that happen in communities. It would be much more efficient for us to try to shape policy than to allow that concentration that will lead to, inevitably, to really significant kinds of behavioral health challenges. That is an example of thinking broader than treatment and thinking about the same kinds of strategies that we use on the public health side. Fourthly, I think we need to think about health promotion strategies. Right now, we assume that if you treat pathology and that if there's an absence of pathology, that is equated to health. But most of us recognize that not being sick is not the same thing as being healthy. And I think one of the things we should be thinking about as a field is how do we help people be mentally healthy, mentally well? How do we use health promotion strategies? Because we know that those are very useful and helpful at preventing and reducing the likelihood that people will have very significant behavioral health challenges. And then the last one, the number 5, is the idea of moving out of what I call the treatment black box, that the way fundamentally we deal with behavioral health issues in this country is we build treatment black box, people get sick, they come into treatment, we quote fix them, and then we discharge. That's the mental model, that's the paradigm that we have. Lots of challenges with that paradigm. Number 1 is most behavioral health conditions are chronic conditions. Certainly the most severe behavioral health conditions are chronic conditions. That is an acute care model. And so there are a lot of unintended consequences for using that paradigm. Number 1 is when people leave, they're not, quote, fixed. And often what happens is when people no longer are symptomatic, the first thing we do is we remove resources from them. So we create disincentives in our systems for people to actually get well. Furthermore, people aren't being supported once they leave treatment, which in ways that would be much more cost effective, that eventually lead to people often relapsing. And so that paradigm of the box is very limiting in lots of ways. One of them is that we focus all of our attention on treatment. And the reality is that behavioral health conditions happen in all kinds of ways. One of the things that I have experienced being at the city level, as opposed to the state level, is that Because I'm embedded within city government, I work with the police commissioner and the fire commissioner and the health commissioner and the child welfare agency. And what is really clear to me is that behavioral health conditions are embedded in all of those systems. And if you ask my colleagues in those systems, you know, what's in the top 2 or 3 issues that you deal with, behavioral health issues are going to be there. Police would say that, prisons would say that, schools would say that, child welfare would say that. And so to the extent that we are only focused on treatment in treatment settings, we miss the opportunity to intervene in other settings. So for example, in Philadelphia, one of the things that we do is we put behavioral health professionals in family court to help advise judges so that they make better placement decisions. That has resulted, and there are a lot of other things we've done along with that, but that has resulted in us reducing residential care for children in out-of-state placements by over 80% over the course of a year and a half or 2 years. So again, it's a way of thinking about our work that's not so treatment focused, that is broader than the treatment black box, that is in other settings, that I think will help us both prevent, intervene early, and intervene in much more effective ways. So I know my colleagues here have some really great points, but I hope I've sort of at least gotten some ideas out there that stimulate some thinking, and that I hope sets the stage for what's going to come. So thank you.
Thank you very much. Now the format will be that I'm going to introduce you to the other 2 panelists, that I will ask them some questions, and in the last 20 minutes, or even before then, we'll have questions and answers from all of you. On the panel is Dr. Bill Beardsley, who is Chairman Emeritus of the Department of Child Psychiatry at Children's Hospital and is Director of a Prevention Program at the Judge Baker Clinic. And with him is Brandon Stagley, who is the Communications Director for the International Mental Health Resource Organizations. And Brandon, I'm going to ask you first if you'd be willing to start. And as a consumer, what has been your experience with prevention and early intervention?
Yeah, so I was diagnosed with schizophrenia in July of 1990, and I received a diagnosis of the disease and concomitant medical treatment within a week after I had my psychotic break. This is much, much sooner than average. In fact, the average length of time it takes for someone to develop schizophrenia to get treatment is a year or more. So I was very lucky to have had friends and family that helped me get consistent treatment right away. And what I did and the programs that were used for me to get better included cooperative family stress management, of course medication and psychotherapy, and engagement in goal-oriented and social-oriented activities. So these were all helpful things for me to recover, and I've recovered very well so far. The fact that I'm here to speak to you today as the Communications Director for IMRO, as she mentioned, International Mental Health Research Organization, and family representative of One Mind for Research, testifies to the efficacy of treatment as early as possible.
And to follow up on that, knowing what you know now, if you'd had an opportunity to participate in a prevention early intervention program before your psychotic break, would you have done that?
The answer would be yes. I think a good way to phrase it would be if I were the person that I was as a college-age student before I had my psychotic break, thinking back to my mentality then. And but if I lived in today's world with current resources for prevention and early intervention, what would my decision be? And it would be yes, I think. Granted, my attitudes toward mental illness were very stigmatized back then, and I felt kind of invincible, as I think a lot of young people might. Given, you know, if I were told how positive the prognosis is for young people who develop a critical high-risk state for psychosis, if they get early treatment, and then compared to, especially to treatment after a psychotic break, then that would have helped me decide toward yes. And then also knowledge of all the new emerging treatments that exist for that can be used in early intervention framework that are non-pharmaceutical in nature, like cognitive behavioral therapy, like family cooperative stress management, like cognitive training, like mindfulness-based stress reduction. Plus, many of these new therapeutic angles can be used in a software-based, apps are being developed so you can kind of pursue these treatment areas at home. That would have helped me decide yes. So I recommend further validation of these new techniques and scientifically, and then also better early detection so that people can be confident that they're going to be treated properly if they're diagnosed early.
Thank you. Bill, why is it now time for us to focus on prevention?
Well, that's a great question, and I think it's important to have a broad vision and to focus on the details. I want to say broadly, we have the evidence that prevention works. We have the evidence that prevention can be implemented widely and that it can be a partner to treatment. And we have the opportunity under the Affordable Care Act to implement public health strategies, because suddenly now the responsibility of everyone in the population is going to be part of the healthcare system. In terms of vision, I do want to recall that this is the 150th anniversary of 1863. Two events there, the great battles of the Civil War that turned the tide and preserved the Union, Gettysburg and Vicksburg, were fought in 1863. But also in 1863, Abraham Lincoln signed legislation to establish the Institute of Medicine with the idea that science should serve the public interest. I've had, as Mary Jane has, as many of you have had a lot to do with the Institute of Medicine, and I think it's provided vital support in this area. And then 50 years ago, we had the passage of the Community Mental Health Act, but it's also important that in late August we celebrated another very important anniversary, which is the March on Washington. And I actually was at the Kennedy Library for a celebration the week before the celebration in Washington. John Lewis spoke there, a friend, and the only person alive from who spoke at the March on Washington. But I think that the struggle for justice and civil rights, for voter access and civil rights, is part and parcel with the struggle for justice and dignity in the treatment of those with mental illness. And I think Kennedy had that vision and saw that, and so I marked that down as a sort of starting place. I had the privilege of working with the Institute of Medicine on a report on prevention that came out in '94. Good report, essentially said this is an important area, but we are not ready for prime time. We don't have enough efficacy studies, enough effectiveness studies, and I think the major finding of our report that we brought out in 2009 is that we now do have a much stronger science base. We talk about prevention programs from preconception on, certainly good prenatal care early in life, certainly care for supporting the interaction between the primary caregiver and the child, for high-risk families, center-based care, home visiting programs as children enter schools, both support for academics and social skills training. Good behavior games, a good example of that. And as we move into adolescence, we actually have strong evidence that we can prevent episodes of major depression. I couldn't have said that 15 years ago. There are now several meta-analyses that show that. And when I was a resident in the early 70s at Mass General, people didn't think childhood depression existed. So we've made quite a good deal of progress. We have also very good programs for substance abuse prevention. And there's now a good meta-analysis that shows evidence for intervention early in the course of symptoms of psychosis can stave off first episode of psychosis. And that's from investigators in Europe. It's also from investigators in Portland, Maine, Bill McFarland. So we really have some very exciting science that supports the idea that we should incorporate prevention. Had the opportunity to work in both Finland and Holland on countrywide programs for the mentally ill. They have different systems, but they both incorporate prevention as a fundamental part of the spectrum of care. I think that's what we need to do. Another big difference between '94 and 2009 is that there's now good evidence about mental health promotion, promotion of wellness, promotion of healthy habits, and so we need to incorporate that. That's what we're all saying. And then a particular concern of mine is how do we render care to families, not individuals? Your story talks very much about the importance of family. I happen to have done a great deal of work with parental depression. That's a family experience, not an individual experience. And treating the individual with depression is a part, but the family's understanding is very important. And I guess the third piece is I do think we need a lifespan developmental perspective. I've been on the board of Mental Health America. I'm on the board of Families for Depression Awareness. I'm very strongly committed to the recovery movement and to not just treating the illness, but dealing with work issues, relationship issues, housing issues, quality of life issues. That should be our target. I guess the final thing I'd say about the Institute of Medicine is that in the report in 2009, we were able to say definitively, based on epidemiologic evidence, that the major mental illnesses of adulthood have their origins in childhood. So we need to pay attention to that. And many of those preventions do not involve medication. They involve family support and talking therapies. And I also want to echo what others have said. I'm very grateful to Patrick Kennedy and very honored to be here today. I know a number of the people in the audience, and I'm interested in what they have to say. I'm sure they know more about this than I do, but I think we are ready to really incorporate prevention under the Affordable Care Act.
Thank you for those comments. And we talked a bit about public health and how do we get our field more mainstreamed in public health. We've been talking about mainstreaming mental health and substance use into primary care and into the medical field. But you're really talking a much broader community-based service system. Arthur, do you have some other comments you'd like to make on that particular issue of the public health dimensions?
Yeah, sure. And I think Howard Coleman's notion of big ideas and incremental change, I actually like big ideas and big change. So that's my style. So, but having said that, I do think, and one of the reasons I'm talking a lot these days about public health is because I do think we need a fundamental rethinking of our field. And I think unless we start to put those ideas out there, we're not going to get the kind of change and traction around change that we need. And I know that, you know, as we stand here today, some of the things that a public health approach might infer, or the kinds of things we might want to do, are maybe years off, maybe even decades off, but I think we at least have to articulate them. And so that's number one. I'm hopeful that, the other reason I think it's important to start to think about these issues now is that I think the Affordable Care Act does give us an opportunity to accelerate some of this, and I'll give you a quick example. So, you know, I mentioned that one of the constraints that we have in the field is how we finance services. It's primarily a fee-for-service, and in fact, what we've done is in fact incentivize people staying, not getting well, because providers get paid based on providing services. I think as we change our financing model and large health systems are now responsible for keeping a population healthy, because that's the incentives have changed, because people will be capitated, large systems will be capitated, and the way they'll make their profit is by reducing the amount of services that they provide as opposed to providing more services, which is the way we're financed now. I think it will greatly accelerate people's creativity about the kinds of things that we're talking about. I think people will start to think about, well, if I'm capitated for these 50,000 lives, how do I keep these folks healthy? I think we will start to become much more creative in that way. I think that we'll start to see people figure out what we all know, all those of us who work in the field, that just treating acute symptoms is not enough, and that if we can provide even minimal support. One of the things we do in Philadelphia is telephonic aftercare. When I've had some minor surgery, within a couple of days, a nurse called me to check in on me, right, see how I was going. Those are sort of routine things that we do on the physical health side that we don't do routinely on the behavioral health side. And I think that once we move to a different financing strategy, I think we're going to see those kinds of things start to accelerate.
Brandon, What is your assessment of the level of public will to really move towards prevention and early intervention?
Yeah, thanks for asking. So I've had an experience directly related to that. So my family chaired an auction called Auction Napa Valley this year. It's the largest annual fundraiser for Napa Valley charities. And we orchestrated the last lot in the live auction to contribute a portion of its funds to mental illness prevention and early intervention program in Napa County. So this lot was a fund-a-need lot, which means that anyone who wanted to contribute to the lot could contribute as much as they wanted, whatever amount they wanted, and everybody's contribution would go toward the beneficiaries of the lot. And so I spoke in favor of this lot, and then Napa County District Attorney Gary Lieberstein, who's here at the conference, spoke also about his son's, the loss of his son to schizophrenia-induced suicide. And musician Billy Dean sang a moving song about sharing for the greater good, and many in the audience were in tears when all these appeals were done. And so the auctioneer wasn't sure how high to start the bidding, and my dad urged him to start the bidding at $250,000 per bid, and he did. And as he called that out, 3 people raised their paddles right away, and one person asked if they could bid $500,000, and they did. And the bidding gradually lowered the price from there, but people bid and bid and bid. And after 10 minutes, $3.7 million have been raised for prevention or early intervention in Napa County in that name. So what did it take to raise this kind of money in such a short time span? Well, public will had to be there, obviously. What it took to tap that public will was the heartfelt appeals, attention to the heartfelt appeals of a consumer and the family member of a consumer. So I believe that what we need to tap that public will for prevention and early intervention is personal communication by consumers and family members, more of that to the public of the need for it.
Well, it was interesting because Dr. Pardis today talked about the role of advocacy and to get philanthropy more interested in our field, and maybe the area of prevention and early intervention will be a more saleable as opposed to trying to, I mean, not that we shouldn't have money for research, but
Yeah.
at least your experience shows that that might work.
Yeah, it worked in that instance,
Yes.
and I hope it continues to. I mean, with the public being so interested in mental health right now, I think there's great potential for more motion in that philanthropic area.
And Bill, what is your feeling about the public will to do this?
I think that I think the public will is there, and we haven't found the vehicle to frame it exactly right. I certainly agree with this eloquence of your statement, and that there are venues in which it is manifest and people capture the stories. I would say there's a fundamental problem in this country that is less clear in places like Finland or Holland, and that is we tend to make the responsibility of the care for children almost entirely the responsibility of the parents. What we need is a much larger collective sense that we're in this all together and that we share in those futures, and not just of children, but of adults. So I think that's the frame. I would also say from a public health point of view, if we look at successes in public health, they are population-based. The reduction in smoking is multiple different endeavors. And Mary Jane and I both knew Julie Richmond, who was the Surgeon General under Jimmy Carter, a longtime mentor to me, and someone who courageously battled the tobacco companies for many years. But it was lawsuits, it was smoking cessation in primary care, it was limiting access of adolescents to tobacco, and a whole series of other things from a public health point of view, with the outcome that the population would smoke fewer cigarettes. And I think that's the frame. I think the other frame is, and it's spoken to by the eloquence of your story, the other frame is that mental illness has tremendous suffering for individuals and tremendous suffering for families. One woman that I worked with said, depression attacks the soul. Another said, it is circles within circles, a sadness out of control. 80% of the people with cancer in this country get treatment. Less than 30% of people with major depression get treatment. Right. So we can't tolerate that. But the positive side is that when people get treatment and get their lives on track, they can be extraordinarily successful. We've seen that again and again in working with parental depression, in which we take a situation in which a family's communication has been shut down by the depression. They're able, through preventive interventions, to have a conversation, to get back on track. And it really releases a tremendous amount of positive energy, positive parenting. So the story with mental illness is both one of suffering, but also of tremendous potential if we can really implement the programs widely and integrate prevention with treatment. I have to say, both as a physician and as someone who's worked in this area a long time, we need the vision, and then, you know, Einstein says, God is in the details. And we need to get the details right about this one. And it's very hard to do. Okay, the website is the least of the problems. But they'll get fixed. But we need to really think about how do we incorporate funding mechanisms to take care of families and reward prevention. How do we frame the paradigm differently than saying we need to do more and more treatment. We need to do treatment, there's no question about that, but we need to add something to it.
It's interesting because some of the issues that were raised this morning about categorical programs and categorical funding remain today. So that when you had the DD money going one place and mental health going someplace else and addiction services going, substance use services going somewhere else, and that we have not, housing, our impact on housing and education, and we remain siloed, and we know that our consumers tend to be the ones that are put aside until everything else, so to speak, is dealt. How are we going to, if we talk today, and there was a lot of talk this morning about the role of the federal government setting the tone, understanding innovation comes from the states, but how are we going to be able to move forward if we continue to have all these categorical programs? And I certainly have spoken in favor of categorical programs when I had invested interest in making sure the money came into what I wanted to do. But I think it's a serious, serious problem. Arthur, you got some ideas?
Well, I think the categorical issue plays out in different ways. So certainly one between sort of large groups, but like addictions, mental illness, and developmental or intellectual disabilities. But I also think that this idea that people have to have a diagnosis to get help is a real problem for our field. And I gave an example a little while ago. We have practically no resources, or very few resources, for intervening with people because our funding is categorical and it's for people who have a certain kind of diagnosis. The reality is, if we really thought about it, people's mental health issues are on a continuum. It's not like this binary phenomena where either I'm well or I have a mental illness. There really is a continuum, and I think the way we have to intervene, if we're really going to take a public health approach, is to really have interventions that can intervene along that continuum, because that's the way we prevent. That's the way we have a more efficient way of dealing with mental illness, with addictions, and so forth. So I think we need to think, about how that gets in our way of really intervening with people, so that we don't have to wait until people reach some threshold before we can actually help people.
I'd like to now open it up to all of you sitting patiently here. The microphone is in the middle of the floor, so if you want to go to the microphone, that will be very helpful. And please, it would be important for all of us if you could introduce yourself and tell us what your affiliation is.
And if we have to say nicely without stomping on each other and running, right? Like we all rushed up here.
Good.
Good morning. It's still morning?
Yeah.
My name is Dr. Teresa Garate. I'm from Illinois, and happy to be here. I used to be a former special education teacher, so my question is going to be related to education and public health. So I think that there's the K-12 system is a great opportunity to both promote public health. I also was the assistant director for the Illinois Department of Public Health for 3 years, so very important issue. But I think there's a very large gap in the K-12 system, both from general education and even special education teachers, understanding mental illness. DD, a little bit more accepted, a little more strategies, much more comprehensive, but around mental health issues, there's a large void. And I think that unless we try to address that or do something even in teacher preparation programs, parents, we're not going to get to where we need. So can one of you address that?
Well, think it needs to start by reducing the stigma surrounding mental illness that many people attribute to it. I mean, the more the public and people in general understand that mental illness is a brain-based illness, it doesn't indicate anything morally wrong with the person who has it, then they'll be more willing to talk about it and fund and support programs, I believe, publicly that can address problems of mental illness. A good place to start, as you say, is in schools. Mental health education in schools, I believe, should be a program that's available to students, that maybe should be incorporated in all public schools. I mean, that would be a great thing, I think. So I think education, is a great place to start.
We could start with mental health first aid training, which I heard last night. Vice President said that it was going to put $100 million or something into it anyway. Next.
Yes, good morning, everybody. I just want to begin to saying how incredibly blessed I feel to be able to be here and participating in the Kennedy Forum and to have the opportunity to hear the four of you. My name is Bob Roussel. Like you, Brandon, I'm a person with lived experience of co-occurring disorders, and currently working full-time as a certified peer specialist with Fellowship Health Resources, which is a behavioral health care organization in 7 states. And I'm the corporate director of peer recovery services for this organization. And I'm also an advanced level RAP facilitator, as well as a master training in the Center for Integrated Health Solutions, Whole Health Action Management. I live prevention education programs and try to make them available and accessible to a wide range of people with a great cultural diversity living with lived experience. And so Arthur, and by the way, Arthur, I heard your keynote at the Wrap Around the World Convention in Philadelphia. Man, you rocked! And and so that was great. So when you said that only 2%, of your budget went to prevention education programming, and I'd like to know what percentage of that 2% actually, and I'm glad Pam Hyde is here if she's still here. What percentage goes to the work that I do, the operationalizing of the programs into the community to increase accessibility for people living with mental health challenges and their family to participate in programs like RAP and WHAM?
Sure. I love that question because I think, first of all, I think the incorporation of peer support into our service systems has had a tremendous impact, especially in Philadelphia, but I think around the country, on changing our service systems. There is, it's one thing for me to stand up in front of an audience of providers and say people can and do recover if we provide the right kinds of services. It's much different if you say that. And so I think the emergence of the peer movement and people with lived experience taking on significant roles within our service systems has been very transformative. So I appreciate your work and I thank you for that. I am so committed to peers and people with lived experience being in our system. I essentially have a set of policies. For one is that we don't make any financial decisions about funding new programs without people with lived experience being at the table. That means family members and people with lived experience. We have people with lived experience throughout our system. They sit on my executive team and they're throughout our organization. When in Pennsylvania has a peer specialist program, but for Medicaid, it is only for adults with serious mental illness. That leaves out everyone else. And so what we've done is we've said to our providers, if you propose a new service, you have to include peers as a part of the staffing complement, and we'll build it into the rate that we pay you. So I think that even though there are a lot of constraints around doing the kinds of things that we think are important for helping the people to engage in recovery and get the kind of support, I think administrators, providers, the broader community has to be creative given those constraints until we can work through those. And the last thing I'll say is that there is a very large group of people within our system. I think when we started our transformation, there were probably maybe 5 very visible people who are in recovery. Just as one barometer, PROACT, I know Pat Taylor is here from Faces and Voices. They sponsor recovery walks around the country. The first one in Philadelphia had 150 people. Last year we had 20,000 people. So we can make a lot of progress. And when you have that many people who are standing up and saying, in this case, I have an addiction, but I'm in recovery, and putting a positive face on it, it makes a huge difference in communities. And again, I want to thank you for that question, but more importantly, your work.
Next.
Thank you very much. My name is Bill McGraw. I'm chairman of the Margaret Clark Morgan Foundation, and our focus is serious mental illness. It's a private family foundation in Ohio. We use most often really the investment model in our work, and always as part of that we look towards sustainability. What can we do that would serve as a catalyst for an idea to continue and grow? These are the best ways to leverage our little operation into some results that really matter and have some lasting influence. So when you talk about public will, this is a real something we spend a lot of time on. We're trying to get our arms around it. We're involved with some efforts that are really I don't need to describe right now, but they are focused on schizophrenia, and early intervention is one of the pieces there. And when we try to figure out what we can do to affect the public will so that that work will continue if we all died tomorrow or ran out of money, if it all stopped. And I keep coming back to this concept of making the business case for early intervention. In other words, if we can prove that all of the costs of treatment in the usual manner that very frequently in the case of schizophrenia involves the legal system, and we know the whole stream of social costs or political costs that result. If we can prove that early intervention is less expensive than that stream of costs, then early intervention will have a life of its own, and it'll be a no-brainer. It'll happen overnight because there can be no opposition. It's better socially, it's less expensive. There's no argument at that point. It's not a political issue anymore. It becomes bipartisan, and it's done, and then we're just work to improve it. So what do any of you know about other organizations or any efforts to work on that proof, the business case, making the business case for early intervention and prevention? Thank you.
Yeah, I think it's a very good question. I think Steve Eos at the University of Washington has done a lot of work on the economics of prevention, and many of the programs are in fact cost effective. Lots of work on investment in early childhood and payoff later on. And in the depression prevention area, there are a number of the studies I've been involved with and other people have been involved in have had cost effectiveness considerations that are positive, good NNTs, numbers needed to treat. I think it speaks to a larger question, which is it's hard to do cost effectiveness research well. You have to build it in from the beginning. You have to have some resources. And so continuing targeted research in prevention, in particular around cost effectiveness, and in particular around how we take things that work in one setting and implement them throughout the population effectively, given the diversity of the population, different families, different cultures, different economic things. That's the challenge that I think we face under the Affordable Care Act. The Institute of Medicine has just convened a forum on implementation and dissemination of prevention. I'm going to co-chair that with Hendrix Brown, but it's very much trying to think about these issues. And I think your questions are right at the core of what we need to do, but we need to be able to have the funds to do the research to evaluate and show cost effectiveness.
Yes.
Good morning. My name is Alice Demna, and I'm with Community Catalyst. We're based here in Boston, but we're a national nonprofit organization that works to increase organized consumer action for health reforms of all kinds. We've been working extensively on Affordable Care Act with coalitions in 40 states, and we have recently, in the last 3 years, begun working on the issue of substance use disorders, really trying to bring together the strong recovery movement and other consumer groups with consumer groups that have a broad focus, have not necessarily focused on any specific disease, to harness all of that power and really bring it for change. And we are beginning to look at the issue of prevention in this arena, and just, as really new compared to many in the room working on this issue. One of the challenges we're having is we're very good at building public will. That's what we have done, and we did that to help pass the Affordable Care Act and other things. Now, we're not going to take all credit for that, but there was a groundswell that really helped us, and is continuing to push the Medicaid expansion in states like Ohio, et cetera. So my question is to the panelists is, where do you see, what are the pressure points that kind of organized consumer action that can build the public will, where do we need to focus, particularly in some of the public health interventions? Public health is not an area, there's been a lot of experience with this kind of organized consumer action. What are some of the other areas that would be the pressure points where we should be looking at to bring those forces to bear?
Well, I think that one of them is we have to deal with the issue of the stigma of having a behavioral health condition. I'm convinced at this point in my career that it's probably one of the biggest impediments. Once you get past some of the structural issues I was talking about before, it's probably one of the biggest impediments to us being able to advance the field. And so I think things like mental health first aid, for example, are really, really important. Number one is, in our experience in Philadelphia, we have, you're talking about big ideas, big change. So we have this, this plan to train 10,000 people over the next 2 years in Philadelphia in mental health first aid. Because I strongly believe that when we get to a critical mass of the population that understands, even at a rudimentary level, and is accepting and understands how to support people as opposed to ostracizing people, that I do think it creates a different dynamic. I like to talk about the PROACT recovery walk because I think many of us in the field have said for a long time, we need to do what we've seen the breast cancer movement do, right? I mean, you see pink everywhere. Everyone knows what that means. And I think it's made a huge difference in the political will to provide the funding. I think it's done a lot in terms of people being more willing to get exams and those kinds of things, to sort of change the climate. And I think we have to take a similar kind of approach to changing the climate. As I said, mental health first aid is one way that we've tried to do it, but there are lots of other things, and I think anything that we can do to make mental health, substance use disorders more normalized, I think it creates that environment. So I think that's one of the major pressure points.
Yeah, I would actually I would add that I think that being able to say we're about strengthening families is a very important message. It's a preventive message. And it's true in the sense of lived experience of people who've gotten help and are able to tell those stories. So I think the family strengthening piece is another hook. You'd asked me before about the political will, Mary Jane, yes. And I think that's one of the ones that I think we can build on with some effectiveness.
One of the big things with stigma, Mrs. Rosalind Carter, a number of years ago established a journalism program at the Carter Center, which I think is probably one of the major contributions that she's had towards eliminating stigma. Essentially taking mainstream reporters, media, electronic, print, social media, social marketing, whatever, and actually bringing these people along so that when they report, it isn't full of myths and misinformation. And we've also been training people from Romania, South Africa, Colombia.
Yeah.
And it's fascinating because, the primitive nature of the way people look at mental illness is not unique to us. It's around the world, as we know. So I think we can't do this alone. We have to be able to find a way to pull in people like the journalists so that they can help us tell our story. Anyway, go ahead.
Thank you. Good morning.
Good morning.
I'm Cinda Jewel, the chairman of the Depression and Bipolar Support Alliance. Hello, Bill. He's on our scientific advisory board, and I appreciate all of you being here. And I want to acknowledge you for being a peer specialist. This is one of the primary programs that we're promoting right now at DBSA. We're one of the few in the country who can deliver the training, and we have an ongoing contract with the VA, and we all know the issues with veterans coming home. What I wanted to talk a little bit about is, I love the title of this panel, is you mentioned education, and I think that's one of the greatest places we can start. Fortunately, my daughter went to a private school with a very advanced social emotional intelligence curriculum that was built into every academic piece of the day. I think this is a big missing in our educational system, because if this was accessible to everybody, people who would be having issues would have ways to deal with it at a very young age. But second of all is, I always, as someone who's experienced both depression and mania and gotten a lot out of both after the fact and during the fact, a little concerned about this notion of prevention. I mean, how far are we going with prevention? I would never want to have not experienced mania. I'm one of the fortunate people that it occurs as a spiritual experience, a revelatory one. I'm sure it's what Paul, who has Saul, had on the road to Damascus, and Saint Teresa of Avila. They would have been pathologized if they lived today. And so this whole notion of putting something as complex as these experiences of life into the pathological model. I think we can all agree that the medical model works extremely well with preventing things like polio, measles, smallpox, all of that kind of stuff. That mental health, which is a process and a lifelong process, does not work so well in the medical model. So what I'd like to see all of you thinking about in terms of both policy and practice and research are things that draw on the strengths and resiliencies inherent in all these conditions. Temple Grandin, who's one of the greatest spokespeople for people who live with autism, is a prime example of another person who has a neurodifference that she would not want to get rid of because of what it's enabled her to do and contribute to humanity. So I just throw that out there. How do you see incorporating programs that really concentrate as much on harnessing the strengths and resiliencies in many ways to mitigate these negative symptoms that we've experienced? I certainly, drawing on my strengths and resiliencies, that's what I have used mostly to mitigate the symptoms. I had to take a very small amount of medication, not apparently enough to really do something, but we know that mental health is alchemy more than science. So I'm just thinking, and it's so hard when you're working in a government setting where there's limits on what you can do and can't do, because you're having to enroll a lot of different people into what you're trying to get done. So I applaud you all, but would just have you think about that a little bit.
Thank you.
Sure. May I respond?
Oh, go.
Yes.
Yeah, no,
Thank you. Sure. So most of the really effective prevention programs that are in use today, they don't focus on medication as the primary line of treatment. In fact, it's the family oriented problem solving and family psychoeducation to understand what the person's symptoms are and what they mean and what causes them, so they can better understand and have a harmonious say on their relationship and support the person toward a more healthy life that works for them. And so I think if that model is continued to be followed, then it shouldn't interfere with anybody's personal and individual strengths and of course weaknesses, but it should. I mean, the idea is to empower the person, not to stop them from developing themselves.
Yeah, and I would add that the models that work are strength-based models that start with the person's experience and respect that. That's certainly what we've done in our interventions. I think the other thing that's vitally important here is all the preventions we've been involved in are voluntary. People choose to be in them or not, and I think that's a respectful way of thinking about this issue. And I applaud you for bringing it up, because it's a very important issue.
Next.
Hi. Good morning. My name's Lynn Grief, and I'm the president and CEO of the National Eating Disorders Association. And with eating disorders, we have about 30 million people at some time in their life will have an eating disorder. And eating disorders rarely travel alone, usually accompanied by another disorder, anxiety, depression, OCD, whatever. So Arthur, this is really kind of for you, big ideas and big challenges here. And I'm also the mother of a son who was diagnosed with schizophrenia and a daughter with just about everything else, including an eating disorder. So I've lived it, I've seen it, and I can't help, and this is a little out of the box, okay, so bear with me, but I sometimes feel that we are reinforcing the stigma. We talk about it constantly, and we use it, and I believe, as a barrier and as an excuse to take big steps. For example, if today we talk about it being the whole health, but we go to a physician and it's neck down. Everything is neck down. Well, eating disorders, they're top to bottom because it's a mental disorder that also has serious physical implications. So I wonder, is there in anybody's vision the concept of a full physical? Our kids go get an exam and they're tested for scoliosis, they're tested for vision, there are screenings for these things. And in the case of my children, they could have been screened for, we're not sure exactly what, but that were some underlying issues. We know we can screen for eating disorders, and it doesn't diagnose, but there's a flag. And if you have that flag, then you can talk to the parents and say, gee, there's a concern here, and it affects her health, her mind, or his health and mind. So to us, screenings would be so valuable, but I think as a field, we're scared to death because of the stigma, and we're reinforcing that stigma by not demanding we be treated as a whole, that our brain should be as respected as our heart and our kidneys and every other piece. So, Arthur, could you ever imagine screening in the city of Philadelphia, voluntary screening?
I am so glad you asked that question. Because one of the things that we're doing, and actually I'm really proud of this, is that we are doing screenings. In fact, we participated in National Screening Day. We got 13 of our providers across the city to participate. We have online screening. So you can go online to our website, Healthy Minds Philly, and it will bring up a website, and you can be screened for PTSD, major depression, anxiety disorder, so forth. Because I absolutely agree with you, and I think this kind of goes back to the whole public health approach. That's something that we do routinely on the physical health side, but we almost practically do it. We don't do it that much on the behavioral health side, and so I think it's a part of our overall. It should be a part of our overall strategy. And one of the reasons we did it online is because there are a lot of people that are they're either not going to walk up to a table. Although we've been surprised at how many people in the subway system will walk up. We have a sign that says, "How are you feeling today?" How many people will walk up and do a screening in public? And many of those folks we've actually connected to services who, frankly, we would not. I don't think they would have ever gone to a community mental health center, for example. But one of the reasons we do it online is that we have a whole generation of people who are just much more comfortable going online and doing these kinds of things. So that is one point. The second point is, and I think Pam would agree, I know Pam is at SAMHSA has really emphasized a more integrated approach to how we deal with behavioral health issues. So one of the things we're doing, to your point, in Philadelphia is a project that is actually federally funded to screen kids in pediatric settings for trauma. In places like Philadelphia, but this is around the country, you have lots of kids who have been exposed to traumatic situations, have had, traumatic stress kinds of situations. And what happens is often it's not identified. Kids develop traumatic stress disorders. And often they don't get dealt with until people are well into their adulthood, after substance use and all kinds of other issues. And so I agree with you. I think that, and then the expectation is that if kids are being screened for other things, we ought to be screening for these kinds of behavioral health conditions and then connecting kids to appropriate services.
I agree with you as well. Yeah, I wish we could do it earlier, but I just finished up a tour as president of a college, and we instituted screening in October, kind of following along with that. And it was wonderful because the students could go online and then they could ask for help and get, so you're absolutely right. We have only time for one more question, and then I've been told that our time is up. So one more question? Hi. Sorry to the other people that have waited, so.
But we'll wait up here.
Yeah, wait up here.
I'm Julie Totten from Families for Depression Awareness, and I know Bill very well. He's on our board, and Mary Jane, and I really appreciate hearing your wonderful story, Brandon, about your personal experience and your insight, Arthur. My question is that we, like some other groups, have a teen depression program, and we're very successful at promoting it directly to families. Like our last webinar, we had almost 1,000 people on the webinar, and we're very good at reaching families directly for this early education. But when we try to reach out to institutions like schools and sometimes religious organizations, we come up against a lot of barriers. So I'm kind of a doer personality, and I like to get things done. And I was wondering, kind of politically, what are the best strategies to get people to actually adopt all these educational programs that we have available? For example, in Newton, where I live, we just had 2 teenagers take their lives this month. So agencies like ours will go and to the school system and start, making noise. And it's a long, slow slog. And it feels like there's got to be some strategies that have worked in a lot of places that maybe we're not thinking of to get the stuff implemented. So that's my question.
Thank you.
Lots of examples. I think one of them is just having relationships. And I mentioned that I'm sort of embedded within city government. And I've developed really good relationships with police commissioner, school district, CEO, and so forth. But I think one of the things that's really important is that as we approach other systems, is to approach with the idea that I'm coming to help you solve a problem that you have. So when we talk to a school district, for example, we know that one of the biggest impediments to children doing well in school is them having a social and emotional problem. So it's kind of how we frame how we want to work with them. So if we can help you help these kids not have this be an issue, they're going to you can focus more on your issue. When we talk to police, it's talking to them about training their officers so that their officers are going to be safe, and as well as a person who's in psychiatric distress. So much so that now when kids, when there's a really bad situation that happens in the schools, the school superintendent calls me. Police commissioner calls me. He talked about this situation where, they have scenes sometimes where kids are around. And he said, when I was a cop, we would just go in, we had tunnel vision, we would just deal with the scene, and then we would leave. But because of the kind of sensitivity that they've gotten to around mental health issues, they're now noticing if kids are around and then calling us and saying, there was a really bad situation, there were a lot of kids out there, you might want to send some folks out to the community. So I think that to the extent that people see that what we're doing is helping them, I think it makes it much easier, and they're much more likely to receive the kind of help that we're trying to provide.
Yeah, I would agree, and I would add that those relationships are usually built not around a crisis, but about an ongoing relationship, and then the crisis is the moment of opportunity to really demonstrate that we can deliver on things.
Well, I think the panel is willing to stay, but yes. I would like to ask all of you to help me thank the panelists for their...
Thank you. Thank you. Thank you.